Hello everybody, I'm back, Dr. KK Agarwal, Heart Care Foundation of India, and you are watching my Talks with Dr. KK non-stop 7 p.m. show. Let's now go to the subject of the day. Yes, we are discussing antimicrobial resistance, and we will specifically talk about the rotational policy of antibiotic, a old aged gadget for us to prevent antimicrobial resistance. Now I can call my special guest, Neha. Neha Gupta is currently the senior consultant infectious disease at Medanta, the MedCity in Gurgaon, and Fortis Memorial Research Institute, Gurgaon. She is part of the first batch of physicians qualified in infectious diseases in India. Her special areas of expertise include HIV medicine, tuberculosis, MDR tuberculosis, bone and joint infection, and implant related infection. She has been awarded the Corona Frontline Warriors Award in 2020, Dr. J.C. Patel and B.C. Mehta Best Paper Award under the category of Original Article for 2018, and Healthcare Award that was a second prize, an award from the DGHS of India and Government of India in 2016. She has numerous publications to her credit. So नेहा जी नमस्ते. हम तो थोड़ा सा लिबरली आपके साथ में आज बात करेंगे, बिटिया हो हमारी. सो सबसे पहले तो ये बताओ नेहा का मतलब क्या होता है?
पहला तो आपके साथ इस प्लेटफॉर्म में आने के लिए बहुत बहुत इट्स अ ह्यूज अपॉर्चुनिटी फॉर मी एंड वी ऑल हैव बीन लिसनिंग टू यू. नेहा के बहुत सारे मतलब होते हैं जो मुझे पता है, जो मैं यूजुअली बताती हूँ, वो ये है कि नेहा का मतलब प्यार होता है. स्नेहा.
So स्नेहा और नेहा, but नेहा also is na e ha a. So the word na gives you relaxation. Ma na na, they are the Nasik Vyanjan. They give you relaxation. E is a vowel. Ha is a sibilant. A is a vowel. So ha basically is a sound. So na gives you relaxation and ha gives you energy. So the one which balances both the energetic phase and the calm state of the mind is what Neha he in front of, and we do a akshar analysis of the word Neha. Na, I, ha, a. Ha, sa, sha, sa, ha are sibilants. They are ushma sounds. And na is a sound. When you speak na, it relaxes you. जब भी आप रोते हैं तो ना की आवाज निकलती है. That's a weeping sound that produces delta activity in the EEG. And ha, the sound ha is a vibratory sound. It comes out from the nabhi, and it basically produces energy in the body. And that's what we want in today's subject. We want both. We want to control antimicrobial resistance, because that's like a neha, that you can use it and misuse it. Proper use is gold, and misuse is like a gun, unused, like gun in the hand of a murk person who can kill anybody. So what is the problem, extent of problem of antimicrobial resistance in the country?
So देखिए, हमारे देश में ही नहीं बल्कि पूरे वर्ल्ड में, इनफैक्ट बिफोर COVID-19 हैज बीन डिक्लेयर्ड एज अ पैंडेमिक, WHO had declared antimicrobial resistance as a huge global threat way back in 2015, and this was because the estimated number of deaths due to antimicrobial resistance, they are greater than any other cause. Like, it is much more than road traffic accidents, or it is much more than patients dying of cancer. So in fact, because of this, because of the high, and the problem is because of the very very impending there is resistance to even commonly used antibiotics. इसके अलावा जो हाई एंड एंटीबायोटिक्स होती है वो भी अभी रेजिस्टेंस आ रही है, जैसे कोलिस्टिन और इवन लाइक कार्बापेनेम्स. कार्बापेनेम इज बेसिकली आईवी एंटीबायोटिक और उसी का रेजिस्टेंस हमारी कंट्री में क्लोज टू 60 to 70% हो रहा है. सो जो हॉस्पिटल में अगर इन्फेक्शन किसी को हम ट्रीट करने के लिए भी अगर एडमिट करेंगे तो वहां पे भी प्रॉब्लम है. बट बिसाइड्स दैट इवन जो अगर ओपीडी में या फिर हमें कोई भी कॉमन इन्फेक्शन होंगी उसके लिए भी एंटीबायोटिक्स नहीं मिलेंगी, तो ओरल एंटीबायोटिक्स भी लिमिटेड है. सो आई मीन
So I'll come back to first of all the need where not giving antibiotics can kill. I'm talking about not giving antibiotics can kill. Say for example, you have meningitis. For example, you have pneumonia. For example, you have sepsis. There, if you anticipate them, not giving antibiotics in time can kill them. In these situations, what to do?
So basically, of course, most important is कोई भी फीवर होता है या कोई भी इन्फेक्शन होती है, तो उसमें हमें एंटीबायोटिक चूज करने से पहले या कोई भी एम्पेरिकली एंटीबायोटिक देने से पहले ये ध्यान में रखना है कि वो फीवर या फिर वो इन्फेक्शन किस कारण से हो सकती है. तो जैसा कि आपने बताया कि पहले फर्स्ट इज टू नो व्हाट इज द साइट ऑफ इन्फेक्शन, वेदर इट्स मेनिंजाइटिस ब्रेन का इन्फेक्शन है, लंग का इन्फेक्शन है, स्किन का इन्फेक्शन है या पेट का इन्फेक्शन है. सो हर जगह पे जो भी इन्फेक्शन है उसके जो बैक्टीरिया होते हैं वो अलग अलग होते हैं और उसी के अनुसार से फिर हमें अपनी एंटीबायोटिक्स चूज करनी होती है. और कॉमनली जो इन्फेक्शन है जैसे यूरिन का इन्फेक्शन वो ग्राम नेगेटिव बैक्टीरिया से होगा, वेयर एज अगर निमोनिया है तो वो न्यूमोकोकल न्यूमोकोकाइस से होगा, स्ट्रेप्टोकोकस निमोनिया से, वो एक ग्राम पॉजिटिव इन्फेक्शन है. सो डिपेंडिंग अपॉन व्हाट इज द साइट ऑफ इन्फेक्शन वी विल चूज आवर एंटीबायोटिक्स एंड इट आल्सो डिपेंड्स अपॉन कि पेशेंट ओपीडी में है कि वेदर इट्स लाइक the patient is in the OPD or the patient is in the patient has received prior antibiotics or not, community से है patient की hospital है, पिछले 3 महीनों में उन्होंने कोई antibiotics ली है कि नहीं ली है, and based on this then we will decide our antibiotics. Plus there are certain infections, for example rickettsiosis, जैसे अगर commonly community में हम देखें कि बुखार आया है तो क्या कारण है, ठीक है, whether it's malaria, typhoid, डेंगू, लेप्टोस्पायरा और रिकेट्सियोसिस, या फिर अगर निमोनिया है तो फिर क्या पेशेंट ने कोई एंटीबायोटिक पहले, या स्किन का इन्फेक्शन है, तो इसके बेसिस पे डिपेंडिंग अपॉन हम ओरल एंटीबायोटिक कौन से ऑप्शंस हैं वो चूज कर सकते हैं. तो कॉमनली लाइक सेफेक्सिम या इवन डॉक्सीसाइक्लिन एट टाइम्स, लाइक इट्स अ गुड ड्रग. पेट का इन्फेक्शन, इनफैक्ट रिसेंटली मेरे फादर को ही इन्फेक्शन हुआ था, पेट का इन्फेक्शन हुआ था. ही इज अ ब्रिगेडियर who's from like and he has not received antibiotics and suddenly he developed very high vomiting and WBC count went up to 22,000. So knowing that he is from the community, he has not received any antibiotics in the last 3 months. Even with a count of 22,000, with God's grace, I gave actually doxycycline to him. And initially IV diya because count zyada the, he was not able to take. The next, and then subsequently I shifted to orally and he did very well. So these are certain depending upon what is the site of infection, depending upon what is the likely pathogen, and what is the likely susceptibility of the organism, based on the prior antibiotic exposure we can choose our antibiotics.
So I'll come back to, again, once you started talking about doxycycline, we have 2 drugs approved by DCGI which are broad spectrum. Broad spectrum means and they are in the national list of essential medicines. That means they have to be available across the country in every chemist shop, and they are broad spectrum. That means you can give them before the diagnosis is made because they are broad spectrum. One of them is doxycycline, second is cephalexin. There are only 2 drugs so far approved by DCGI, and the criteria for broad spectrum is it has to be indigenously produced, cheap, effective, less prone to antimicrobial resistance. Any drug which is highly prone to antimicrobial will not come into the category of broad spectrum. So doxycycline is a broad spectrum drug. It is against as some antiviral effect. It reduces metalloproteases, so it has an anti-M1 macrophage effect, an anti-inflammatory effect. It has an anti-typhus effect. It has an anti-leprospirosis effect. It has some anti-dengue effect. And it has broad range of antibacterial effect. That is its primary effect. So do you feel that when it comes to doxycycline, it can become the drug of broad spectrum antibiotic to be used till the diagnosis is made?
So, in some cases, yes. In some cases, probably no. So, as I mentioned earlier, I'll start with, like, for example, if the patient has got a urinary tract infection. So,
No.
doxycycline, it does not really work for the
Agree.
UTIs. If there is a meningitis, which is because of
No.
strep pneumoniae, then again, we will not prefer that. But yes,
Typhus, yes.
so,
But typhus,
yes,
yes.
typhus, absolutely, we will choose doxycycline. Rickettsiosis, which can present with fever, undifferentiated febrile illness. There is pneumonia. There is also there is Eshkar with brain involvement, aseptic meningitis. Doxycycline is the drug of choice. So it all will depend upon the site of infection. Doxycycline is good for the pneumonia as well. It covers atypical organisms. Plus, it will have, like, again, if there is no prior antibiotic exposure, Streptococcus pneumoniae will also be covered, which is the most common organism for the pneumonia. Skin and soft tissue infection, again, doxycycline is good. It is also a protein synthesis inhibitor. So again, it will, it has this for group A beta hemolytic streptococci. Although the first drug will be a beta lactam, but doxycycline also has effect on the Staph aureus. So if there is an abscess in Staph aureus, doxycycline is good. And of course, as I mentioned, intra-abdominal infections, it is a good choice as well.
So that's the reason we give it in travelers diarrhea. We also give it as an anti-inflammatory. Trials are going on osteoarthritis. And in any way, it is a good drug for acne, where it is given for a longer period of time. And in blepharitis, also skin infection, doxycycline is given for a good period of time with that.
But
So
at the
coming back to COVID, do you feel that in secondary infections in COVID, one of the issue is mycoplasma? Secondary, I mean, you are seeing in Vedanta, what is the experience of secondary infections in COVID? Secondary infections in COVID.
Okay, so basically the bacterial infections in COVID are not that common if the patient gets ventilated. It's basically I'm talking about suppose the patient is on steroids, then then the patient can get secondary bacterial infections. And also if the patient is on ventilation, then there will be again secondary bacterial infections with resistant pathogens. So we are not seeing much of atypical infections in patients with COVID. So Mycoplasma chlamydia we are not really seeing them. It's basically the resistant, probably Pseudomonas, Acinetobacter, or even the Enterobacteriaceae. These are more common. And the other thing which I have noticed also is patients, when they are on steroids, then they may develop fever. That is because of sometimes the gut related bacteremia, like gut say, and in those cases, Enterococcus is also a significant pathogen. So there may be fever because of that. So there again, like, doxycycline, there in those cases, doxycycline can be effective.
So doxycycline मेरे शरीर में मेरे अपने अच्छे बैक्टीरिया को मारेगी क्या? Then I need to have a lactobacillus for that.
No, for all my patients, I have not given lactobacillus. None of my patients have had diarrhea following doxycycline. Unlike the other beta lactams, I have not really noticed. It's not a
So
problem with the doxycycline. No.
if I want to give a doxycycline, is it a part of the protocol in your COVID management to give doxycycline?
No, actually, I don't use doxycycline. No.
In the management, you do not. In COVID management, what is your practically house?
I know a lot of people use doxycycline.
What is the protocol in Vedanta? What is the protocol in Vedanta?
For treating COVID-19?
Yes, as a asymptomatic treatment in 80% of the mild cases requiring no anti-inflammation and anti-thrombotic state.
Yeah. So for mild cases, I'm just giving symptomatic treatment. In some patients, we are giving this oral anti-flu drug, probably favipiravir, depending upon, but as such, it is basically a symptomatic treatment, and also Budecort inhalers, which we usually begin on day 5 to day 7 when they start having some cough. So budesonide inhalers. Otherwise, it's
Bitter.
usually just a symptomatic treatment. Yes.
Okay, so now I want to pick up a person who is sick enough. Okay, so now I'm going a little bit on at a cellular level. When the virus enters my cell, it produces a interferon gamma response outside my cell, which produces my initial local reaction, which is fever. If the gamma interferon response is not proper, if the gamma interferon response is proper, I only get a small fever and my virus disappears and everything becomes all right. Now, if interferon is not working, if the response is not proper, then two things will happen. One is Th1 response, the lymphocyte response comes in, and that Th1 response will produce TNF alpha, IL-6, and IL-8. These are the three bacteria will come, the three interleukins will come, which will produce a high-grade fever. Systemic inflammation they will produce. Fever will be more than 101. If that is not being able to control the disease, then the intracellular virus will produce a suicidal bomb called inflammasome, which through nuclear factor kappa beta pathway will produce internal IL-1 beta and IL-18, which will try to kill and explode the cell and kill, causing an alternative mechanism for inflammation. Apart from that, on fifth day, this happens on day 3, day 4, and day 5. On fifth day, the Th17 response takes over. There is a IL-8 and TGF beta and interleukin 17, interleukin 6 will recruit neutrophils. So the first phase, day 3, is lymphocyte recruitment. Day 5 is polymorphs recruitment. Once the polymorph starts recruiting, they behave like a makdi ka jal. They make neutrophilic extracellular trap, and they trap everything together, which attracts the platelets and the thrombus forms. So we have two types of inflammations. We have inflammation occurring on day 1 and 3, which is immunoinflammation. And we have day 5 when we have thromboinflammation. So thromboinflammation has more Th17, more neutrophilic response than the lymphocytic response, and which causes platelet aggregation. Okay. So the criteria which I am using based on this, so I always pick up my patients. I want to prevent thromboinflammation on day 5. Thromboinflammation would mean CRP rising, coming down, and again rising. That's thromboinflammation. D-dimer starts rising, platelet starts reducing. That's what thromboinflammation is. So what criteria I am using, I don't know what criteria you use. The criteria I use is I would give them doxycycline and ivermectin. Ivermectin is approved by the government protocol. Doxycycline, I give it as more as an anti-inflammatory because it can precipitate, it reduces metalloproteases. So I need a drug which can take care of anti-inflammatory and has some antiviral effect. With that, what I do is I check I now want to check, are they going towards a IL-1 beta response or not? And my criteria there is a fever more than 101 or CRP more than 10. So if I see a patient has a IL, they have a CRP more than 10, or they have fever more than 101, in the primary infection, I'm not talking about secondary infection with systemic inflammation, that means the pneumonia has set in, and I start steroids and anticoagulants at that particular moment, which is day 3. By day 3 or by day 2, if I see any evidence of a hyperinflammatory response to prevent a thromboinflammation. To prevent a thromboinflammation, I pick up these cases, which will be say around 10% of the cases, and start treatment early so that they don't end up into a catastrophe later on. What's your protocol there?
So most of the patients who actually I see, they're already on doxycycline and ivermectin.
Doesn't
Very
matter. I,
mild
I'm talking
cases,
about,
yeah.
I'm only talking about picking up cases, picking up early pneumonia. How are we picking up early pneumonia on day 3? Because if you come with a pneumonia on day 7, 8, or 9, you end up into a problem.
Yeah, so actually, in my experience, what I've seen is definitely we need to look at the patient profile first. We all know that COVID-19 has been associated with very high mortality in patients who are obese. So, a high BMI, more than 30, has in those patients very high risk of mortality. And all this hyperinflammatory phase going into cytokine storm, etc. So, and the second thing which you have mentioned is absolutely right is the fever. Fever is very important sign which can actually help us in predicting those patients who are at a high risk for progression. So, in my experience, what I have observed is that if the fever is more than 100.5, and if it is persistently spiking, very high fever, persistently spiking, it may come down with Dolo 650 a little, but high fever, persistent, and then patient developing some little cough. So they, in fact, they don't say that cough ho raha hai. They just say कि नहीं नहीं thoda sa hi hai. But that little cough, and sometimes even that chest pain, a little heaviness in the deep breathing, especially on day 4, day 5, or even like on day 3 itself, like a lot of patients persistent fever, that is a very high risk for progression. And day 5 to day 7, it is this like inflammatory response can happen to in these patients, which may take a catastrophic completely
So
outcome.
one thing I'm saying is I would start steroid and anticoagulation at that particular moment when I
Absolutely,
see.
yes.
And
Bilkul.
also, if their 6-minute walk test shows a shortening of the distance by 100 feet. Nothing.
Absolutely. So, like in such patients, plus what happens is at times there is a fever which is going, then it may just dip a little for a day and then suddenly shoot up. So, that is again the inflammatory response which has happened. So, it's here where they need an effective antiviral drug, plus obviously anti-inflammatory drugs like steroids, and of course anticoagulation. So this time around, like last time, we definitely saw a lot of coagulation abnormalities. We saw patients who had very high D dimer, but this time the in this virus, what we are observing is a thrombocytopenia. We did not have so much of thrombocytopenia last time. Here we are seeing a lot of drop in the platelets, leukopenia. There is elevated CRP, plus D dimer at times is not very high. So that's the difference which we have seen. But yes, anticoagulation and all such patients will, hospitalized patients. तो बात की बात है अभी तो empirically at home to prevent any further complication. This is what we have to do. Anticoagulation, anti-inflammatory.
I want to go back to the antibiotic rotational policy. But before that, I want to say is because in this wave, there is low platelet count, which more often will occur in the second infection than the primary. After vaccine, COVID, or after COVID vaccine, or reinfection, there we are seeing low platelet count. I am of the firm opinion that low molecular weight heparin in the second wave should be taken out. It should be NOVAC, because some of them, if they develop heparin-induced thrombocytopenia, which is a similar pathophysiology, it can harm. So I'm shifting all my patients not to take low molecular weight heparin if they have thrombocytopenia in this particular way. Just an observation, keep it in mind that some patients who are serious in the hospital not responding, I'm asking them to shift from heparin, low molecular weight heparin, to rivaroxaban or apixaban or whatever you want to shift them. Sometimes it helps. Now coming back to antibiotic rotational policy, tell something about why do we need it? They were the antibiotic rotational policy. We used to do it in gentamicin, 6 month gentamicin, 6 months this, 6 months that. Why antibiotic rotational policy is important?
Yeah, it is very important, and that's because when a bacteria is exposed to any antibiotic, whether it's rational, whether it's appropriate, or it's not really appropriate, it acquires resistance. So when we are using an antibiotic, and it's more rampant in use as well, the bacteria will acquire resistance. So there will be resistance to that particular antibiotic. And if an antibiotic is not being used, that is, if the bacteria is not exposed to it, then there will be return of the susceptibility to such antibiotics. So as we have seen, even like at times, even chloramphenicol, which is an old drug, we have seen susceptibilities to this particular molecule. Besides, we have obviously, like in, as I mentioned, for the patients who have not received antibiotics, uh, certain drugs which can be taken orally, like doxycycline, they are effective and they are susceptible as well.
So हम लोग इसको
Especially
इस
like
ढंग
if
से,
it is a gut pathogen, I think doxycycline is a good molecule.
so
Gut
there are
pathogen, skin and soft tissue.
two
Yeah.
types of mutations which occur. One is called as a substitution mutation. One is called as a deletion. For example, IPL match is going on. You substitute a player, that's a substitution mutation. आप बोलो कोहली को कि तुम 3 नंबर के बदले 1 नंबर पे आ जाओ, that's a substitution. And deletion means कि एक player injured हो गया. So injured players deletions usually may not recorrect, but because of the proofreading mechanism in our body, substitution types of mutations can recorrect itself, and that's why when you do a antibiotic rotational policy, कई बारी resistance खत्म हो जाता है and the bacteria becomes sensitive to the virus, to the antibiotic again. कौन कौन सी एंटीबायोटिक्स हैं जिसमें हम रोटेशनल पॉलिसी कर सकते हैं?
Think, so well, like say for example, we can do it with obviously the beta lactams. We can do it with the aminoglycosides as well. Looking into the nephrotoxicity pattern. कि ये है. और उसके बाद में we have commonly we have the tetracyclines. Of course, उसमें क्या जा सकता है? And the quinolones. Quinolones are usually now resistant. So the antibiotics which are likely to be susceptible, फिर वो यूज करके हम इन्फेक्शन को ट्रीट कर सकते हैं.
So coming back to again, I have lots of people waiting who want to ask questions. But before that, let me spend a couple of minutes back to doxycycline as a revision. A, it's a broad spectrum. You say yes, no. I'm only enumerating the points. So, doxycycline is an broad spectrum antibiotic. Say yes.
Yes.
Yes. So I'm only revising. You go on saying yes. So doxycycline is a broad spectrum antibiotic. Two, it has antiviral, antibacterial, antiparasitic, anticlamidial, and anti-typhus effect, and anti-inflammatory effect.
So I would say definitely it is a broad spectrum antibiotic. It is a protein synthesis inhibitor, so it has some anti-inflammatory effect as well. It is a very good drug for rickettsiosis. So that's again the drug of
Leptospirosis,
choice,
rickettsiosis,
as well as
leptospirosis,
leptospirosis. Yeah,
and
but for
typhus.
dengue and for viruses, I
Okay,
think
so
yeah.
it may have some antiviral effect. Add the word may. It may have some antiviral properties. Coming back to this is a drug with least AMR. So we have penicillin even today. Penicillin even today we have seen it is still when we talk about streptococcal rheumatic heart disease prevention, it is still sensitive to that. Doxycycline resistance is much less seen than
Agreed,
other.
agreed. Yes, agreed. Yeah. Especially even among the gram negatives and those who are in the community with no recent prior antibiotic exposure. And one of the things is also advantages with doxycycline is least allergy. Like if there is allergy to the beta lactams, doxycycline is one drug which has the least allergy among the antimicrobials.
So that's a good point for me. It's a new learning for me, because every time when I discuss, I have never added this word. So every day I can't sleep without learning something new. And that's a new learning, is that somebody says I'm allergic to antibiotic. मेरे को कोई एंटीबायोटिक सूट नहीं करती, उसको डॉक्सीसाइक्लिन दे दो. So that's a new learning for me, because normally people say that I'm allergic to many of the antibiotics. And नेहा जी says, नेहा जी कहती हैं कि अगर आपको एंटीबायोटिक से एलर्जी है तो डॉक्सी से तो नहीं है ना, डॉक्सी तो ले ही सकते हो. लेट्स हैव few of the questions. सुरेश गुप्ता, we have, let me take some of the people from who want to ask some questions. Yes, सुरेश जी बोलिए.
डॉक्टर साहब नमस्कार जी. सर मैंने 21 तारीख को कोविशील्ड का फर्स्ट डोज ली थी और 22 तारीख को मुझे 99.5 फीवर हो गया सर. मैंने मेफ्टाल ली तो मेरा बुखार उतर गया. अभी मुझे कोई सिम्टम नहीं है, लेकिन मैं ब्लड थिनर ले रहा हूँ सर. और कुछ लेना है क्या सर?
नहीं, आपको कितने दिन के बाद बुखार हुआ वैक्सीन के?
नेक्स्ट डे हुआ सर, सेकंड डे.
तो एक बार RT-PCR करा लो, एक बार वो भी करा लो, पता लगा कि see Neha, we are seeing a peculiar cases in Delhi. Now normally if you go for a vaccine and next day you start developing symptoms of COVID, you say bullshit. You say it can't happen. You say that you might be harboring an infection, because the incubation period is 4 to 5 days. It is 2 to 14 days, average is 5th day. But of late, I am seeing 1 to 2 patients every day. That second day, they are positive. This subject I am debating for the last 3 days with all the experts. That is it something like that the vaccine, if you take vaccine today, then your immunity becomes so different that if you get exposed to the coronavirus, then it gets facilitated. The virus gets facilitated. I'm calling it as a facilitated corona. It's not breakthrough, because your antibodies haven't formed. Somewhere it is behaving like a disease enhancement. So observe in your practice, if you start getting people who are positive in the first week after the vaccine, that number is increasing. And so I only tell them to get the corona test done, and majority of them are turning out to be positive. And it is initially we used to say, no, you might have carried the infection with you and you might be having asymptomatic positive, but this is vaccine enhanced, facilitated COVID-19. I observed it then I started reading the literature, and then there was a debate going on in Israel on this particular comment, and everywhere they say we don't know what is happening, but that phenomena is being seen with that. Shivam Srivastav.
हेलो
Yes.
सर, वेडनेसडे को मेरी स्मेल गई थी, संडे को वापस आ गई, बट उसके अलावा मुझे फीवर भी नहीं हुआ, खांसी भी नहीं हुई, बट मुझे पिछले 6 दिन से सुबह सुबह जो कफ हो रही है उसमें रेडनेस आ रही है. आज मैंने अपना एक्सरे करा है, वो नॉर्मल है और ऑक्सीजन लेवल भी 98 है.
बोलिए नेहा जी. नेहा जी, इनका कारण ये कहते हैं कि मेरे को बल्ले बल्ले कोविड हुआ है. बल्ले बल्ले कोविड मीन्स लॉस ऑफ स्मेल, लॉस ऑफ टेस्ट, विच इज यूजुअली माइल्ड, विच हैज either no or mild pneumonia. Number 2, he is saying is कि मेरे को निमोनिया तो इन्होंने बोल दिया है कि हल्का सा कफ में ब्लड आया है. So he has a loss of smell, loss of taste pneumonia with mild pneumonia. What to do? क्या एडवाइस करेंगे हम इनको? शिवम जी, नेहा जी बताएंगे आपको.
ये बताइए कि शिवम जी, आपको फीवर अभी आ रहा है?
नहीं मैम, मुझे फीवर फर्स्ट डे से नहीं आ रहा है, वेडनेसडे से मुझे फीवर नहीं आ रहा है, और ये मेरा 11th डे.
करेक्ट. सो आपको सिर्फ एक ही दिन फीवर आया था, ओनली ऑन डे 1?
नहीं, मुझे फीवर आया ही नहीं था डे 1 से. मेरा जो हाईएस्ट टेम्परेचर गया था वो 97.6 गया था.
आपने फिर कोविड टेस्ट इसलिए कराया था क्योंकि आपके जो
स्मेल गई थी.
स्मेल गई थी. आपके घर में कोई कोविड पॉजिटिव है?
नहीं, मेरे घर में बाकी और कोई कोविड पॉजिटिव नहीं है. मेरी स्मेल गई थी वेडनेसडे को.
और आपने फिर कोविड टेस्ट कराया जो पॉजिटिव आया?
जी,
है ना. ओके. देखिए, आपको एक्चुअली जैसे इन्होंने बोला, सर ने बोला, बेसिकली इट्स अ माइल्ड कोविड, एंड ये जो आप बोल रहे हैं कि आपको ब्लड आ रहा है, वो आपको गला खराब है?
गला खराब है, और एक्चुअली जब वेडनेसडे को मैंने टेस्ट कराया था तो मेरे राइट वाले नोज में मेरे थोड़ी सी चोट लगी हुई थी, और फ्राइडे को
हम्म।
जब टेस्ट हुआ तो उसी में स्वैब डाले हुए थे। और मंडे
हम्म।
से जब भी मुझे शाम में या सुबह थोड़ा थोड़ा भी कफ आता है ना, तो उसमें
हम्म।
हल्का सा रेडनेस टाइप का रहता है, और वो 6 दिन से लगातार है।
ओके।
छह
तो
दिन से
आपके
लगातार है,
बेसिकली
और
नाक
एक्सरे।
में प्रॉब्लम है? नाक में प्रॉब्लम
नहीं,
है?
नाक में मेरे भी कोई प्रॉब्लम नहीं है। 6 दिन से जब
हाँ।
सुबह सुबह कफ आता है तो हल्का हल्का उसमें हल्का सा रेडनेस होता है। और
हम्म।
मैंने आज अपना एक्सरे कराया है, एक्सरे एकदम नॉर्मल है, ऑक्सीजन लेवल 98% है।
जी। देखिए
मुझे
आपके
11
जो
डेज हो गए।
सिम्टम्स हैं, हाँ बिल्कुल, देखिए आपके जो सिम्टम्स हैं, क्योंकि आपको फीवर नहीं रहा है, आपको खांसी नहीं आ रही है, तो बेसिकली ये जो सिम्टम्स आप बता रहे हैं वो आई डोंट थिंक इट्स फ्रॉम द लंग्स, इट इज प्रॉब्लम फ्रॉम योर अपर रेस्पिरेटरी ट्रैक्ट। ठीक है। सो उसमें आप आप या फिर आप, अगर आपको खांसी भी नहीं है, राइट? कि खांसी
नहीं
है
नहीं,
आपको,
हमने
शिवम?
इनको ले लिया, आप बोल दीजिएगा क्योंकि हमने इनको अलग कर दिया है।
ओके। सो बेसिकली अगर कुछ लोगों में ऐसा होता है तो मे बी ब्यूटिकॉट इनहेलर विल हेल्प इफ देयर इज कॉफ, अदरवाइज इट इज गोइंग टू बी मोस्ट प्रोबेबली फ्रॉम द अपर रेस्पिरेटरी
In
ट्रैक्ट
any
एज
way,
यू।
in any way, anything which is loss of smell, loss of taste is a
यस,
mild
एब्सोल्युटली।
case. These are mild
यस।
cases, nothing to worry. Yuvraj Khurana.
सर गुड
युवराज
इवनिंग।
बोलिए।
सर मेरी मदर को सैंपल दिया था हमने ट्यूसडे को 20th को, और शी टेस्टेड पॉजिटिव। अभी क्या है कि उनका थर्सडे को रिपोर्ट पॉजिटिव आई है, तो घर पे ही होम आइसोलेशन में थे। बट अभी आज जैसे उनका जो ऑक्सीजन लेवल है दैट इज कमिंग डाउन टू 87-88। और
So
अगर वो
Yuvraj, so I will take, because the time is less. I will only take Yuvraj case and discuss it out. बाकी लोगों को हम नहीं ले पाएंगे because Yuvraj case will take some time. I want to take Yuvraj case. And where is this lady? Yes. So Dipali. हाँ. So basically आपको फोन अपना बंद करना होगा। आप बताइए पहले तेज की बताइए।
हाँ सर, मदर की मतलब दोनों वैक्सीनेशन लग चुकी थी। एंड ट्यूसडे को सैंपल दिया था। फादर ऑलरेडी हॉस्पिटल में एडमिट हैं। एंड तो मदर का भी सैंपल दिया, तो उनका थर्सडे को हमारे पास रिपोर्ट पॉजिटिव आई। तो हमने नॉर्मल जो अजिथ्रोमाइसिन और जो ये नॉर्मल ट्रीटमेंट आता है वो
आगे चलिए।
अभी सर आज सुबह से उनका ऑक्सीजन लेवल डिप हो रहा है टू 87-88। अगर जब वो प्रोनिंग पोजीशन में आते हैं तो
आज कौन सा डे है?
आफ्टर सिम्टम्स सर, रिपोर्ट से मैं बात करूं तो आफ्टर सिम्टम्स टुडे द 6th डे सर।
सो
6 और 7
आप हमारे से अभी मैं ये शो खत्म करके दूसरा शो पे आ रहा हूँ, इस पे आप आके बात करके डिस्कस योर ट्रीटमेंट। अनदर 5 मिनट आई एम रिपीटिंग माय शो, उसमें आप आइएगा। सो नेहा जी, इससे पहले कि मैं समाप्त करूं, बिकॉज मेरा दूसरा शो है अभी, आज मेरे 4 शो हैं बैक टू बैक। सो नेहा जी, दिस इज क्लासिकल केस आई एम सीइंग नाउ। दिस इज V1, that means vaccine 1 taken, plus V2, vaccine 2 taken. So I say V1, V2, 2 vaccines taken. Like an ECG, we start talking about V1, V2. So I say this is called V1 COVID and V2 COVID. So this is a V2 COVID. He has received 2 vaccines. Now these are the cases where what I am observing is, because of V1, V2, they have developed non-neutralizing antibodies. These are binding antibodies which are not neutralizing. Therefore, they have not prevented the infection. Because they are non-neutralizing antibodies, I say these are local antibodies which have produced protection to, which has now, this antibodies have led him for 2 things. Now on the 8th day, he is developing happy hypoxia, not on the 3rd day. So 8th day happy hypoxia means he has thromboinflammation. He has, and this thromboinflammation characteristically we are seeing after the second vaccine, first or second vaccine. So after vaccine, if you develop COVID pneumonia, it will invariably appear on days 6, 7, and 8. In these cases, the CT scan pneumonia may be negative on day 2, day 3, and day 4. I call them as post V2 thromboinflammatory pneumonia with happy hypoxia. Any comment you want to make? This is the last minute I have.
Yeah, absolutely. I think this is the time where patient is very serious. She receives an antiviral as well as anti-inflammatory, strong anti-inflammatory agents. Plus, obviously, anticoagulation also will be needed for her.
So that's all for today. युवराज जी, आप मेरे से अभी जैसे ही मैं शो खत्म कर रहा हूँ 1 मिनट में मैं दोबारा चालू कर रहा हूँ. 8 बजे का मेरा 7:30 का शो है, 8 बजे का शो है और 9 बजे का शो भी है. 10 बजे तक मैं 8 से 9 बजे तक मैं आपके साथ लाइव हूँ. तो आप लोगों मेरे को नेक्स्ट शो में आप आके बात करिए. I'll discuss with you. That's all for today. Let me say thank you to Dr. Neha Gupta for coming here and interacting with us. नेहा जी, आज आपके इस शो को कितने लोग देखेंगे? अंदाजन कितने लोग देखेंगे?
I don't know. आप बताइए.
फिर भी अंदाजन 100, 200, 300, 400 कितने लोग देखेंगे? आप क्या सोच के आई थी कि आपके शो को कितने लोग देखेंगे?
वैसे मैंने कुछ सोचा नहीं था, लेकिन आप पूछ रहे हैं तो हाँ, मैं बोलूंगी कि
100-200
अब
देख
आपका
लेंगे.
भी शायद नहीं, 1000
जाएंगे. कम से कम आपका नंबर 10,000 क्रॉस करेगा.
ओके.
ओके, I'll send you the figures by night. आपके
ठीक
शो
है.
को कम से कम 10,000 से ज्यादा लोग वॉच करेंगे. Thank you everybody and we'll be back tomorrow 7 p.m. with another show. Keep watching Med Talks with Dr. KK. आज का शो बहुत मैसेजेस आपको मिले होंगे. अच्छा लगे गिफ्ट के अंदर में लोगों को लिंक